Welcome to Cardiovascular Insights from the University of Cincinnati Medical Center. I'm Dr. Richard Becker, Chief of the Division of Cardiovascular Health and Disease and Director and Physician-in-Chief of the University of Cincinnati Heart, Lung, and Vascular Institute. I'm joined by Dr. David Feldman, Director of Advanced Myocardial and Circulatory Services in the Division of Cardiovascular Health and Disease and Director of Clinical Services of the Heart, Lung, and Vascular Institute. Dr. Feldman, the first international mechanical circulatory assist guidelines which you authored were published in 2013 by the International Society for Heart and Lung Transplantation. Now that we're almost 2 years from that publication, I have two questions for you. The first is, what is covered in the guidelines? And secondly, why are guidelines so important?
So the guidelines start with the pre-evaluation of who would be an appropriate candidate for somebody who would need a ventricular assist device or mechanical support. And ventricular assist devices we always abbreviate as, in common nomenclature, as VADs. So who would be eligible for a VAD is partly determined by a lot of other things, because it's not about just fixing their heart, Dr. Becker. It's about fixing their whole bodies to resume what would otherwise resemble a reasonably normal lifestyle. So it covers very specific aspects of how to optimize heart function in a very sick heart. It talks about the psychosocial aspects that are mandatory in order to make sure that these patients are successful, because the surgery is only a portion of this. It's about the management of these patients and by the caretakers and by the healthcare team after that. There are aspects of this related to the technical aspects of the surgery. There are aspects of this related to the perioperative management of these patients. There are portions of this that are dedicated to the management of these patients after being discharged from the hospital and how to follow them long term. There are also even portions of this about what to do when things go wrong. And for those patients that are not eligible for things like this, including palliative care and hospice, if in fact it's not appropriate, as every medical therapy that you can imagine is not appropriate for every patient.
Yes, and you make a good point in terms of patient selection, and even though the technology may exist, that for certain individuals, one may choose not to go a particular route.
That's exactly right. You know, every patient does not benefit from an operation. And unfortunately, this is a lethal disease which winds up being life-limiting for a lot of people. And if we are not going to make a difference in either the outcome related to their quality of life or their quantity of life, then we choose not to do this. Sometimes deciding not to do something is the hardest decision of all.
Yes, and I think you in part have answered my question about why guidelines are so important in terms of this broad swath of patients and options for their management. Are there others that benefit from having these guidelines? Payers, healthcare, particularly in the affordable care era, who actually benefits from these guidelines?
I think that really they're meant for the community in general. By the community in general, I mean that it helps healthcare providers, it helps insurers, it helps third-party sources like the federal government and state governments make determinations. There are really very few programs that actually put in mechanical support devices, and you can quantify those as probably only a couple of hundred in the United States. So you divide that by 50 states, and really all of a sudden you're down to double-digit number of programs. And because, in fact, this is such a high-end, complex therapy for so many patients, what we've tried to do is we've tried to standardize that no matter where the patient should go, irrespective of which hospital, that they get a level of care that would meet or exceed those guidelines.
Yes, perfect. So you provide optimal care for those individuals, assuming that there's a team that's been assembled of experienced providers. Can you tell us a little bit about the program that you're building here at the University of Cincinnati Medical Center?
Thank you for asking, Dr. Becker. Well, you started to allude to this, and this is actually absolutely correct. You don't build a program with one person or two people. This is a multidisciplinary approach where you combine A lot of people. Some of them are surgeons, some of them are physicians, some of them are cardiologists, some of them are not cardiologists, infectious disease doctors, pulmonologists, psychologists. Then we have very, very important aspects to the team that are not physicians at all. Our social worker is key. Our nurse practitioners and our PAs are key. The nursing staff related to the heart failure management and the chronic disease illness management program is key. Our palliative care doctors are essential. We also integrate even clergy into our program, along with PharmDs and dietitians, and the list goes on and on. What we're all doing is we're trying to get a large group of brains focused on a patient to produce a single best outcome every single time.
Yes, extraordinary and so valuable. I want to start to look into the future. Now you've first authored the guidelines. You've really set the stage for optimal care. When you look down the road 2 years from now, 5 years from now, what kind of therapies would you expect to be part of a program like the one that you're building at this institution?
Sure. So, advanced medical therapies, of which ventricular assist devices are part of, I think that, we will continue to have the logical expansion of services. Ventricular assist devices can be used as a bridge to heart transplant. They can be used as a bridge to support patients for stem cell therapies or for cell-based therapies for the hearts to heal themselves. I think what we're going to see eventually is that the batteries that actually support these ventricular assist devices now last less than a day. I think that we'll see that the batteries will last longer. And unfortunately, because they do require a power source, because they're literally taking the place of the left side of the heart, usually, sometimes the left or the right, what we see is that, in fact, right now, these patients actually need energy. Eventually, all of that energy, much like is contained in a pacemaker, will be self-contained within their own bodies. I think that will be a game changer. Total artificial hearts are also coming a long way, and I think with time, we will be able to see patients that otherwise would not have survived even 10 years ago thrive.
Sounds like this is the touch point for patient care, education, training, and research. And the patients are the beneficiaries of having these teams put together. A very exciting time indeed. I'd like to thank Dr. David Feldman for joining me today on Cardiovascular Insights.
Thank you for having me.